Arriaga, and her title of her presentation is Designing Theory-Driven Technologies for Improved Health and Wellness. And after the presentation, please ask Rosa questions, turning on your mic and just say it, please, because there are lots of chat issues and I don't know how to handle it actually right now. So just please ask it out loud. You can do it in Polish and we can translate it into English if you want. So, okay.
Also, if you're shy, you can always email me. So you can email me, help, let Google Translate help you a little bit, or maybe you can just try to just, you know, I can understand. So thank you so much, Veronica, for inviting me. I'm really honored. I've never been to Poland. So, you know, it's nice to attend at least virtually. And I am going to go ahead and share my screen now.
Yes, please. And I will turn off my camera.
Okay. All right. So as Monica said, I'm going to talk to you today about design and how theory plays a role in it, and especially in the area of health and wellness. So I'm going to go ahead and give you a general introduction to my research agenda. So what is it that I do, you know, in my workday? And I think part of the call today is for impact, and I will argue that computing systems can, and I think should, address fundamental problems in chronic care management, so people that have diseases that last a long time, but also mental health. And I'm going to present some theories that drive my research. And then I'm going to tell you about some lessons that I've learned after being in computer science for 15 years and some of the work that I'm doing now and in the future. So as you might know, my PhD is actually in psychology. And in psychology, we study human thoughts and perceptions and behavior. And of course, you know, psychologists pride themselves on being scientists. So we make observations, we make predictions, we test predictions, we develop interventions, sometimes to improve human condition. And theories are very important. Why? Because we want to be able to generalize to other humans. But now, and for the past 15 years, I'm a computer scientist. And in particular, I'm in the area of human-computer interaction. Now, I always tell people that human-computer interaction is the academic name, so what you call a professor that does UI, UX design, right? So if you're in industry, you call it UI, UX. If you're in academia, you call it human-computer interaction. And this is a study of how people at a very basic level interact with, you know, computers, where now computers mean many, many things. And really the focus is on how do we design and deploy systems that are useful and usable and enjoyable, and that allow the users to meet their goals, because that's the most important thing. And at Georgia Tech, as you know, we're a top 10 computer science program in the US. We also have something that's called human-centered computing. So that says, you know, okay, let's not think about, you know, even the human and the computer, but let's think about computing that puts the human in the center. So it's not technology for its own sake. And so we have a broader understanding of how computational artifacts affect or transform the human experience and culture. So this very much is, you know, the socio-technical system. And I'll come back to call this socio-technical system something else. So in HCI, human-computer interaction, we have a different method, right? So the idea is that we are going to use this user-centered design where we do this kind of systematic, evidence-based, iterative cycle of needs assessment, design ideation, prototyping, and evaluation. And if you are interested, you can take the free course on Coursera. So you can take the user experience design course that I teach on Coursera. I think that's how Veronica found me. And so there, it's the same. Yeah,
Sorry.
and so that's how in this class, this Coursera class, this is how this is the same class that we teach the undergrads at Georgia Tech and the foundations for our graduate HCI course. And so, you know, in HCI, the contributions are either pragmatic or futuristic. You know, what am I going to build now? Or also, and these can be novel interactions or interfaces or systems, but it can also be more ideas. You know, what ideas do I put into the world about this design implications and guidelines? And once again, the kind of deliverables in HCI are very different from the deliverables in science. So, you know, where do HCI and psychology meet? Well, I think that, you know, computational systems provide a way to scale human effort over time and space. So you can think that a psychologist or a doctor can meet one person at a time, but technology can really reach many people. So, you know, in psychology and social science have proposed a number of theories that can be helpful in HCI research. And, you know, this is what I'm going to talk to you about. And so once again, the main point of my talk, right, the premise, is that really human-centered computing can improve the human condition. And I'm going to define what that means. So, yes. All right, I think somebody had to turn off their mic.
Yes, hello, sorry, can you people turn off your mics? You are interrupting our guest.
That's fine. It happens. So why HCI? You know, why do I care about health? Well, in the US, it's a very big problem. So 17% of our current gross domestic product, okay, goes to health spending. And we don't have the best health in the world either. So you might say, well, you're spending a fifth of your gross domestic product, but you have the best medical care in the world. But that's not the case. Our medical care is actually quite bad compared to, you know, European systems. And, you know, and even worse than that, you know, in the US, this chronic disease, these diseases, heart disease, diabetes, leads to 7 out of 10 deaths each year. And this is according to the Center for Disease Control. So health is a really important question. All right, so I'm going to define what I mean by chronic disorder. So a chronic disorder must last more than a year. It must limit your function, your activities, or your social roles. It leads to some dependency in medication or diet or technology. And then it requires some kind of intervention, either medical or educational or psychological. And this is compared to other people the same age, right? And so, of course, you know, we can think about physical health like asthma. We can think about developmental disabilities like autism, or we can think about mental health like PTSD. And today I'm going to tell you a little bit about my research in these three areas. So I try to design technology that that bridge these major gaps in chronic care management and that improve wellness. So what does that mean? So the first thing I want to do is I want to engage the user, right? In the US, we find that something like, you know, less than a half of the people that get a prescription will get it filled, right? And that they may not adhere to their medical regimen. So how do we engage people to take care of themselves, right? So what are the current treatments and practices, and then where can we use technology to help them? Then we have, maybe you've had this problem, you haven't gone to the doctor in a while, you had some issue, but you get to the doctor and the doctor says, how are you? And you say, I'm fine. Okay, so there are these 2 points in care, right? And there's nothing to link them. So there's no way for us to actually understand what happened between these gaps in care. And so, you know, again, how do we build technology that bridges this gap? So now we know what went wrong. And then the other part is, how do we use technology to mediate communication, So you get to the doctor, and now you can actually tell the doctor what you want to say. And again, I don't know what the conditions are where you are in Poland, but in the US, the average time with a doctor might be 10 minutes. And, you know, in the US, we have something called waiting room amnesia, which is basically you get to the doctor, you forget everything because you're stressed, right? And so the idea is, what would the care provider, what would the doctor want you to know? What would you want to tell the provider? And so how can we be self-advocates or advocates for those that can't, like their children or maybe our parents? So how do I do this? Well, I design systems that support a variety of stakeholders, right? And that's where really we move from HCI to human-centered computing. We have to understand if there's a human in the center, you know, that individual, right? It's not just the individual, but it's families, it's professionals, it's clinician. And that the other thing that's important to me is I want to use technology that's available now, right? I care about mobile phones, social media, and anything that's robust. Why? Because robust systems work in the real world. I have a friend, you know, and he does, all sorts of future computation. But to me, you know, if I can't help somebody now, then I'm not interested. So that's one of my biases. And so people have and need different kinds of help. Some people need physical help, some people need wellness, some people need mental health. And because I'm interested in such a wide range of conditions, it really means that I have to have domain experts, right? At the end of the day, maybe I'm a technologist, but I'm definitely not a pulmonologist. I'm definitely, you know, not a psychotherapist or psychiatrist. So it's really important for me to have these individuals on my team. And the other thing that's important to me, and really, I think where I may differ from other HCI researchers, is that I want to move beyond this needs assessment phase, because I also want to think about the theories about human behavior and cognition, right, that are going to help us provide better care. All right, so I already told you the definition of chronic disorders, and first I'm going to tell you about physical health. And here, as you know, you may know somebody that has asthma. In particular, a lot of my work has been with pediatric patients. And the idea is that these kids have a dependency on medication, and you know, they might need to see their doctor more often than other children, and they're also going to need specific education about their condition. And so, as you know, asthma is actually a big problem worldwide. It's the most common chronic disease among children in the world, according to the World Health Organization. All right, so then we come back to the question that I'm interested in, is how do we help? You know, how do we improve health outcomes, right? So now the point here is that, you know, with asthma, we have data, right? Because that's the other thing that's important to me, that it's evidence-based. We have data that they have, you know, they're having a flare-up, and this can be, for example, their lung function. So how do we improve the health of children? You know, you can say, well, what technology do we use? When I did this work, you know, the most common technology for children was texting, right? How do we design a system to improve health outcomes? So I'm going to tell you about a particular approach using this theory. And then, how do we know that our system has worked, right? And this is something else that might mark me from other HCI researchers. If you want to know in science, right, in clinical trials, then you would do a random control trial. And so we did a random control trial for the system that I'm going to introduce you to. So as I mentioned, I'm going to tell you about two theories, and the first one is the health belief model. And the question is, what variables can be used in intervention? So the health belief model was started by Rosenstock, and it basically has to do with cognition, right? It's a cognitive perception-based model. And the idea is that people's beliefs affect the way they act. So how do people think, how sick do people think they are? What are the benefits of engaging in a certain medical regimen? And what are perceived barriers? And then along with the individual beliefs, there's also things that modify it. It might be your age, your gender. We talked about knowledge, the way you know something, but we know, right? I mean, I love sweets, and I know I should probably have only one cookie, but I might have more than one. So the question is, for us in asthma, we wanted to think about children, and we said, what if we modified their knowledge, right? So we're going to teach them more about asthma, and then we're also going to help them understand that they're sick. And here I want you to think about this. One of the biggest reasons why people don't go to the doctor is because they don't think they're sick, right? And the way that doctors and therapists have explained it to me with asthma is people will be breathing like this and they say, doctor, I have no problem. Why? Because they've gotten used to it. And so the question was, can we get the children to understand that they actually have symptoms that are actually bad? And will this help them, right, engage? That is, do something about it, take their meds, and will this lead to health outcomes? Okay, and so that was our goal. And so along the way, I'm going to introduce you to the grad students that I've worked with over the years. This is to remind you that you too can come to Georgia Tech and have your PhD or have your master's in computer science or in HCI. And so, the questions that I was interested in is, can we use texting based on the health belief model to improve health outcomes in children? And the outcomes I'm going to look for is going to be lung function, right? Because that's a physical objective measure of whether they're getting better, but also quality of life. Is it useful? And then will the patients engage with the system? I can give somebody a text message, but they may ghost me, as they say, maybe they say this in Poland too. So will it be usable, right? So back to these two features of good systems in HCI, useful and usable. And so again, because this was a random control trial, and importantly, this was in the wild. So these are, this is an intervention that took place over 3 to 4 months, right? So we would see kids that were 10 to 11 years old. They'd have, we collect all sorts of data. We take the log data, right? Did the kids answer their text? Did the doctor check out what they had answered? And then we see them again 3 or 4 months later. And this is not on our timeline, but this is, if you were going to have a meeting, an appointment, we would be there to meet you. And so what were the text messages? We had 2 kinds of text messages. So the symptom message, right? So the severity question was, in the past 4 weeks, did you wake up at night with wheezing or difficulty breathing? Right? So again, we're reminding the patient, how severe is your asthma? And then with the knowledge question, we would ask them a question. Everyone's asthma is the same, true or false. And then if they got it correct, then we'd say correct. Everyone's asthma is not the same, and then we'd give them a factoid. In fact, people with asthma can have different symptoms and different triggers. So again, to this matter of education. And so physicians, right? So the kids would get the text messages, and the physicians, the doctors, would get the visualization of the SMS responses, right? So we talked about, engagement, and that's what we're trying to get from the patient. Continuity of care, we're trying to get with the physician. And so now, whenever the kids had a certain number of them right, they would get these green points. If they had too many symptoms, then they would get this red line. And this would, if they got too many symptoms, then they could actually email the doctor. Our system would automatically email the doctor to say, look, this is a problem that your kid is having. And the idea is that this would facilitate the conversations we'd have, because now, remember I told you that we wanted to bridge the point of care interaction. So now at the point of care, we could say, or the doctor could say, you've been taking, too much of this emergency inhaler, because now we have the evidence of what happened, right? So again, it would facilitate communication at point of care about asthma symptoms and about the children's asthma knowledge. And now we talk about impact in the world, and this system at some point was licensed to Isonia, which was an asthma health company. All right, so I told you that we were going to do a random control trial. In the first study, we had some kids that had nothing. Some kids would get a text message about the symptoms, right? Did you wake up at night wheezing and coughing? And then the other kids would have two text messages. One day they'd get symptoms, and the other day they get knowledge, right? Is everybody's asthma the same? And so we found that kids that got daily text messages, right, Monday through Friday, actually had improved lung function. Okay, so over a 3-month period, their lungs got better. But it wasn't only that their lungs got better, but they also reported a better quality of life. So now, we have some evidence that this is actually working. Now, in HCI, we do a study, we do it once, and we say, great, it worked. However, right, as a social scientist, I don't know why it worked, right? Can I replicate it? Was it just a spurious statistical finding? The other thing is, can we extend the results? So we know, right, you might remember that the knowledge-only texts were combined with symptoms, but maybe knowledge only is what's driving the impact. Then there's other conceptual issues. So, is the system equally effective in two distinct demographic groups? And I'll tell you what I mean by that in a bit. So in the US, we have this language about at-risk groups. And at-risk groups are really groups that have low literacy. They might have low-paying jobs that then allows them, that focuses their attention on immediate needs and not on health. And so that puts them at risk for many things. And so we find that in the US, asthma disproportionately affects poor individuals. And then, as you may know, in the US, Black Americans have been disproportionately affected through many issues, including institutional racism, right? And so we actually find that Black children in the US are 5 times more likely to die from asthma than a white child. And this is because, more often than not, they live in more impoverished conditions. So this is even more serious for people that are poor and people that are disenfranchised. And so what we wanted to know in the next study is, how can we look at this issue of demographics? And in the US, we have people, one of the ways, these proxy variables, is insurance. So if people have private insurance, because in the US we don't have socialized medicine, so some people get very good insurance, and usually these very good insurance has to do with very good jobs, right? If you have a very good job, then you get insurance. If you're very poor, especially poor children, because poor adults can't get insurance unless they're senior citizens, then you get public insurance. And to be in public insurance, you have to be very poor. So again, this is going to be a proxy variable for being at risk. And so the good news is we find that we are able to replicate, right? That not only kids that have insurance, private insurance, right? So kind of probably their parents are better educated, have better jobs, it works for them, but it also works for the poor kids. So the poor kids that probably have, are at risk for many other things, it works for them. If they get 2 messages a day, they're actually going to get improved lung health. However, the great thing is that if you're a poor child, if you get one text message every other day, you're also going to have improved lung function. So again, we find that our system, right, our computational system is useful and usable. That, we had adherence about, 90%, and that it actually worked. All right, so just to summarize, we found that it's useful, that patients' lung function improved. We found that it's usable, that patients are willing to provide continuous information between the visits. And then you said, well, Rosa, what happened to the doctors? The doctors gave up. They never went on the dashboard again. And so here you have this system where we don't even, need the doctor to check the dashboard, because just having this interaction is going to help them. All right. So now I've told you about asthma and this physical health, and now I'm going to tell you about autism, okay? And here our goal is not going to be necessarily for health, but it's going to be for wellness. And I'll tell you what I mean by that. So as you might know, as autism, right, is characterized by difficulties in socialization, sensory sensitivities, communication, restricted interests, and repetitive behavior. In the US, about 1 in 68 children are diagnosed with autism. It's about 1 in 42 boys. So it's a very common, you would say, condition for children in the US. And you would hear that it's called autism spectrum behavior, because it's a spectrum. So now the American Psychological Association has these 3 levels. Level 3, you require a lot of support. You may not have language. You may have mental impairments. I'm interested in level 1. So level 1 used to be called, at some point people had the term Asperger's. At some point they used to have the term high functioning autism. Now we just refer to these levels within the spectrum. So I work mostly with level 1. These individuals have normal language. They have normal or above average IQ. And most of the problems that they have to do with social skills deficits, right? And so what we want to do is we want to improve their independence, to improve their sense of wellness. So the challenges in autism are that these individuals have many caregivers, right? I talked to you about the pulmonologist and the child with asthma. Here, the parents have to help. There's educators, there's clinicians, there's therapists, there's physicians. So there's a lot of caregivers involved, right? And the interesting part is that the caregivers and the individuals with autism require different care. So some of it is specific to the individual with autism. For example, one child might have light sensitivity, right? But there's some information that's general that anyone can provide. And this tension between the individual information and the general information is what I'm trying to provide some solutions. All right, so now I'm going to talk to you about the second theory. This is called the ecological systems approach. I'm going to check my watch to see how I'm doing. I'm doing okay with time. And so in this ecological systems theory, what I'm going to think about is how technology is situated in an individual's life. And so you can see, this diagram is very social science. There's arrows, there's circles, there's, all these things going on. But the basic idea here is that development is defined in terms of how the individual interacts with people in different levels. So it's not just the child, right? It's not just that individual, but it's their, the different levels of people around them. And the degree to which these interactions are back and forth. So it's not just one, unidirectional. We have these, these things that come back and forth. And so what I did in one of my first papers in HCI was we said, okay, how can we think about it in a kind of an easier way? And so now in this ecological systems theory, we're going to say that we have a child, with asthma, or in this paper was about asthma, but we're going to say about the entire ecosystem. So not only the child, but now we're going to be thinking about all the layers. And so here, the power lies in providing a framework that defines how to systematically think about this. So it reminds the user about the entire ecosystem. And then the idea is that now it can help us think about how would you build technology at the individual, at the family, at the community, at the society level, and so on. And so this is very much the approach we use with autism. And so I'm not going to tell you about all of it, but I'll just tell you that over the years, we've built technology for the individual. We've built technology that worked for the parents and the clinicians inside the home, that we've built technology that works at the community, the family, and the individual level. That we've even done studies that look at what are the sociocultural aspects. For example, how does tweeting tell us about people's conceptions about autism in different cultures? So I looked at India and the US. But here, as you might imagine, the question is, well, what about society? Can we build these systems at the society level that would allow us to get children help? And so this is what I'm going to go through briefly since my time is running short. So we had two systems I want to tell you about. In the first system, right, I told you that what I want to do is I want to look at current practices. I do not want to invent practices because I'm not a therapist, I'm not a psychologist. So I look at a practice like going to your doctor 3 or 4 times a year. Here, it's a particular therapy called social stories. And in these social stories, these are instructive narratives that teach these level 1 individuals with autism about how things function in the world. So this example is, how do you drink, from a water fountain in order? And so it helps the children cope with everyday events and obstacles. And it gives, here the caregiver writes a story that's a general sequence of events, right? And then you can understand if this child has specific issues, that you would put that in the narrative too to help. And this is pre-COVID because all the kids are not wearing masks and everybody's drinking from the same faucet. So the idea is you have an author and you have the crowd. So again, if we think about the web and we think about crowdsourcing, we wondered, can we get the crowd to help us facilitate this task where the task is writing a story about some goal in their life? So the author, right, knows the child and can focus on the child, and the crowd, right, for example, Amazon Mechanical Turk, which is what we use, provides content for the social scenarios. And so I won't go into the details, the paper information is here. You can go to my Google Scholar sheet. But basically what we were able to do is we were able to take the crowd workers to come up with suggestions. If you go to the deli, or, I'm going to say McDonald's or Subway, what are the steps, right? What are the steps for going there? And the idea is that now the mom can start writing it and can use the steps in here, or she can put her own steps. And then we also get individuals to write, what are the obstacles with, once you get to the fast food restaurant. Okay, so here I've told you how we can use the crowd to help us write this therapy, this kind of social story. The next one I want to tell you about is, so one of the troubles in HCI is you can only see so many people, right? You might interview 10 people and try to get saturation, but one of the nice things that these platforms afford us, and there are places online where people with autism go. There was one called Wrong Planet, okay? And so people there go and talk about things they care about. So again, as an HCI researcher, when we're looking at needs assessment, I really want to go here because now you have these individuals on an autism forum that are talking about things they care about, not things that I'm asking them about, right? And so you know, so great, they go to this forum, but the problem might be that people that go to the forum have the same cognitive profiles, right? So individuals with autism have certain characteristics. They might provide too much information. They might sometimes miss some common sense, you know, issues with privacy and security. And so the question is, you know, how good is the advice that these individuals are getting? Or is it too limited because everybody in the group, right, is homogeneous? And so the idea is that we have the individuals on the forum and we have the individuals in the crowd, and the crowd has knowledge about what's socially accepted interactions and behavior. And so what do I mean by this? Well, one of the questions we came up on in the forum said, I'm having trouble, so this is the question, I'm having trouble with my neighbor in the apartment. They make too much noise. What should I do? Okay, think to yourself, if you're having trouble with your neighbor, what would you recommend to this individual? All right, well, the answer, the first answer that was on the website was, well, what you do is you wait till 3 o'clock in the morning, you take out all your pots and pans, and then you pretend to be Ringo Starr. This is not the right answer, right? And so, you know, the question is that a one-time situation, or is this actually what may be happening? So we did a study where we looked at questions that people on the spectrum had asked, and then we compared it to the answers in the forum. And so we actually found that compared to the answers from the forum, the people on Mechanical Turk, so you might know about Mechanical Turk, these crowd workers, first of all, they were more rapid, so they could answer faster. They gave more direct answers because, again, part of the cognitive profile of individuals on the spectrum is that they can ramble on, right, and give indirect answers. So they were direct, they were concise, they were informational and prescriptive. They said, first you do this, then you do this, then you do this. And also, this advice was actually very emotionally supportive, because you might say, well, people don't go online because they want information. They go online because they want support. And the good news was they could get all the positive aspects of being in the crowd, or pardon me, being with other people that they thought was like-minded, but they also would get the emotional support. All right, so in the last couple of minutes, I'm going to tell you about the work that I've done in mental health. And once again, PTSD, I'm going to tell you about it, is a trauma and stressor-related disorder. So basically, people will re-experience some intrusive nightmare. They avoid the trauma-related situation, thoughts and feelings. They have negative alterations in thoughts and moods, and they're hyper-aroused. And again, in the US, this is a big problem with veterans. So in the general population, about 1 in 10 Americans might have PTSD. It's actually lower. But in the US, about 1 in 5 US veterans from Iraq and Afghanistan are going to meet the criteria. And so I really love this quote because it's so powerful. It says, I'm left with basically nothing, too trapped in a war to be at peace, and too damaged to be at war. And so one of the things we wanted to do is to understand basically veterans and how are they currently getting help. This is some of the most current research. Again, if you want any of my papers, you can always, email me or go online to find them. And so this is one of my current grad students. We did semi-structured interviews with clinicians, with civilians, with veterans. Okay, so this is very much an HCI study with needs assessment. And, some of the results were recruiting veterans is hard, right? In the US, veterans can be distrustful, and, they may not want to actually, be in a study where somebody can know who they are. And the idea is that we want to provide tools that give patients feedback about engagement with the clinician, and that helps us collect data outside. So one of the things about veterans, and this is in the US, is that they're very stoic, right? The military teaches them to have a certain way of presenting themselves. And so that they're stoic, right? So no emotions, that they don't complain, and that they don't talk about their problems. Well, this is exactly the opposite of what should happen in a clinical setting when you go to a psychologist or a psychiatrist. And so you have this problem. And so one of the things you might want to do is collect information from outside the clinic, the dyad, to some trusted others. And so this is work now that I'm going to tell you about, that's with the another clinic here in the US, where the most successful therapy for PTSD. So one of the best things about post-traumatic stress disorder is that you can recover from it. So if you're suffering from PTSD, you can get better. And this therapy called prolonged exposure therapy is the most common. And the idea here is that they help you understand that these feelings, memories, and situations are not dangerous, and they don't need to be avoided. Because remember, we talked about how do we know that, sometimes students say, Dr. Arriaga, how do I know that I'm actually having a psychological condition? And the question is, if you can't do your daily activities, right? If you're avoiding something and now you are less able to function, then you have a problem. So with PE, we tell them that, that these situations are not dangerous and that they're not to be avoided. And then there is this scale where 1 is no stress and 100 is incapacitating stress. So we try to get patients to get very good about understanding what their stress level is, so that they can understand when it's getting better. And so there's two parts of this PE therapy. One is a clinical session. So there you're going to tell me what's the bad thing that happened to you. And while you're telling me, you're going to report the subjected unit of distress. And the second homework, right, is going to be that you listen to this narrative. So I'm going to audio record when you told me this bad thing that happened to you. And for homework, right, you're going to listen to this narrative. And then the psychologist is going to get you to confront the stimuli in the real world. So we call these in vivo exercises. And when you're doing your in vivo exercise, we're going to ask you to report your distress. So, this is not real example, right? This is a mock example. But, the idea is that there are wrong, their perceptions are wrong, right? I knew something wasn't right. That is a wrong perception, right? That will lead them to think that they could have done something, right? We know that now they're afraid of kids crying and screaming. And it turns out that, in this mock example, they hurt children. And so now they can't be anywhere around children. So again, the homework would be you listen to this, and then with the psychologist, they come up with some things to do. Like you're going to sit at a park bench, in the early morning, you're going to sit at a park bench in the middle afternoon, and then you're going to sit at a park bench on a Saturday when there's a ton of kids, okay? And the idea is that you need to do this. Now, the problem with PE is that it's very hard to deliver. And the problem is that we have to rely on patient self-report. So you ask the patient, did you go to the park? And they say yes. Did you stay for a half an hour? And you say yes. But you and I have had the experience where, when something is awful, you're there 10 minutes and you're like, okay, it's been a half an hour, I've got to leave. So we rely on patient self-report, right? So there's no ability to collect objective data. So these are the trouble. And then the other thing is it relies on clinician intuition. So now how good is the therapist, right? And there's a difference. And so this means that if you have novice therapists, there's limited decision support tools to help understand where somebody is in their therapy. And again, this lack of objective data is really important. And so this is a new project that I'm doing. This is my most current work, where we're trying to use UBACOM, right? So kind of sensor data. We're trying to use HCI, and then we're trying to use machine learning to figure out how to improve PE delivery. And so, you know, there's, I'm going to tell you just the main parts. The main parts here is that we have an app, right? We have a phone app that allows us to know where they are when they turn on the app. So again, patients will only turn on the app when they're doing their therapy. They say, I'm going to do the homework, they turn on the app, right? I told you that PTSD has a physical arousal part. And so we look at, we have a Fitbit to look at heart rate. We have a connection to get information about how they're doing at home or with friends. And then eventually we're going to do natural language processing on the imaginal narrative. And so, you know, I'm going to fly through this because I'm out of time. But the idea is that, you know, we had the example of saying, did you go to the park in the morning? Well, now we can know that they went to the park. We can know part of the therapy is you have to stay still. You can't walk around. Well, if I'm walking around, you can already tell. And all these things are important because if you don't do the therapy the way it's supposed to be, it's not going to help you. It's like the doctor tells you to take 2 tablets and you break one into a quarter and you put it. It's not going to help. And so again, the idea is that all of this can help give us feedback to improve care. And that there is a way of getting this objective measures of engagement. And then, of course, in the end, we want to figure out how can all the data we're collecting help us predict maybe who's going to get better, how they're going to get better, and how to actually improve our partner's practice at a university. All right, so I am just about out of time, so I'll just recap. So I've told you that mHealth interventions for asthma, and I've shown you how I've improved self-care and how this led to improved outcomes, how we had improved continuity of care, and how we were able to mediate a patient-physician communication. I've told you about crowdsourcing for autism, and again, how we were able to show that this was useful and usable. And then I've told you about the work that we did in prolonged exposure and continuous sensing, and how you know, we're working to try to improve the health of individuals with post-traumatic stress disorder. I am at time, so I am going to stop now, and in some future invitation, I'll give you the rest of my talk. I'm going to turn it off. I'm going to go to
well, you can use a bit more time if you want. It's okay.
Do you have 5? Do I have 5 minutes?
Yeah, sure. Okay, it's okay.
All right, so I guess I'll finish then. Thank you very much, Veronica. All right, so I want to tell you about what I've learned, right? So I've been doing this for 15 years. What have I learned? Well, first, when you use theory to build technology, the systems you build are generalizable, right? So remember, when I talked about the health belief model, it was about human behavior. It was not about asthma, although I used it for asthma. So then it means that I should be able to use the same system with a different illness. And so in fact, I did. I took that exact same system and I was able to use it with diabetic pediatric patients. I used the exact same system and I was able to work with adults that had congenital heart disease. And sometimes working with different demographics shows you when things work and they don't work. So we found that people would use, the adults would use the text messaging system, but we found that it wasn't useful. We found that it actually stressed them out. Why? Because when you have congenital heart disease, if you're getting worse, then the only thing that will eventually make you better is heart transplant. And so for this group, text messaging was not a good idea. Again, the important thing is that we learn about how the system works. The second lesson that I've learned is that the design implications are transferable. So you saw that I was able to use this ecological systems theory with kids with asthma, but we could also use the same theory with veterans that had PTSD. So the design implications were transferable from one context to another. And then there's also surprising work. So this is other work that I've done recently. As you might know, if you follow human-computer interaction, the most famous conference in the world is the Human Factors. They call it CHI. So this is work that she's presenting this year about medical makers, and this was related to COVID. And so the question is, if you think, you know, all this time I've told you about the individual, that is the individual medical maker. But the other thing we looked is how does the artifact, and so she studied how these makers were making personal protective equipment, right? So how can we use this ecological approach to establish how PPE production happened during COVID? And then the thing that I find the best thing about it is that this ecological systems theory really broadens our definition of caregiver. So remember when I showed you the initial one, I had a question mark by society. And the question was, can society actually help? And the answer is yes. And so, you know, we told you, I showed you that we could build this technology that would have the crowd, right, provide care. And so, you know, I told you about this crowdsourcing, but it turns out that, you know, the way that somebody completes a set of actions is also very, very culturally relevant. And so this cultural relevance is important because you can get information that's unique to a context. And so one of my favorite examples is we had a lot of crowd workers from India. And so one of the obstacles was that the electricity goes out. Okay, well, the electricity going out is not a problem in the US. But if we were looking for individuals, you know, in a place like India where this is a common problem, we'd want to know about that. And then that actually by looking at these platforms like Reddit, we get to understand veterans' needs beyond the people that are in front of us. So I've told you that I'm working with veterans that have PTSD, right? So you think, oh, all veterans have PTSD. Well, no, it's not true. But, you know, veterans have different needs and they are a group that requires help. So how can we use the crowd to do that? All right, so there I am. So I want to conclude by telling you that I have shown you how computing can alleviate the negative impacts of chronic disorders. I've shown you how theory has important implications for HCI health research. And I've told you that the future is ripe with opportunities for HCI to improve patient engagement, continuity of care, and point of care interactions. And I hope that you can think about how you might build technology that might help people in Poland. So thank you very much. I also say a special thank you to all my PhD students without whom this wouldn't be possible. So that is it. I'll stop sharing. I'll come back so you can see that I'm actually here and that I'm not a robot.
Thank you very much for a very interesting presentation. And we actually have a few questions, but
great.
First is from me. So I wanted to ask you about this application that you are using. You are using it just to see what people are doing, or are you using it to tell them you should stay still in the park, for example? Are you confronting them or?
Yes, so we're not, but the idea is, like you guessed, there's a patient dash, there's a app and a dashboard. And so the clinicians are now going to be able to say, I noticed that you only did it for 15 minutes and you were supposed to do it for 30 minutes. And so the idea is that the clinician is now able to say, you know, maybe today try staying the 30 minutes,
Okay.
Or you said you were at the park, but I see that you're walking around. Maybe tomorrow try to sit down. So the idea is that if we have objective behavior, then this will help the patient. And I think you're right, Veronica. We guessed that the next level is to give the patient the information themselves so that they can see how close they were to actually doing therapy the way they should.
Okay, that's very, very interesting idea. I think the application probably helps also if they are not confronting the physician, actually, so they are not get stressed that somebody is telling them you should do it differently. So I think it's
That's
very,
right. That's right. That's
great.
right. So that's the other advantage of having a patient dashboard.
Okay, so I will now. There are some questions in the chat area, so I will read them to you. So first is, we have many theories about autism. Which theory of autism and autism therapy have you used in your research and proposals?
Yeah, so again, as you know, autism is a spectrum. And so I work with the individuals that are considered high functioning. They used to be called Asperger's, right? We don't call them that anymore. So for example, we use this therapy called ABA. So looking at more of cognitive. So you understand, some children are self-injurious or they're aggressive. And so we've used this ABA therapy to figure out, if you have the behavior, what's the antecedent and what's the consequence. So I think that in general, I'm very attracted to cognitive therapies. And so these cognitive therapies, some work with children that have a lot of problems, and some work with, individuals that have more social problems. And with the social problems, you saw that we have this, it's called social story therapy. Because, again, if we look at the cognitive profile of somebody that has autism, we see that they have a lot of frontal lobe issues. Planning is difficult. And so they have to do things in a very restricted way. And so, but they can learn, right? But the problem is, if you can imagine all the things that can go wrong, it's hard to understand all of them. And so that's where the crowd is very helpful.
Okay, thank you. So I read the next question. What were the criteria for selecting children with autism for testing and applying the solutions you proposed?
Yeah, so the criteria was that they have to have a diagnosis. So they have to have a diagnosis, and they have to, and the parents and the teachers already have to know social stories, right? Because again, when we're doing these studies, we don't want to introduce the therapy, then we don't know if it's the therapy or our technology. So for us, the criteria was that these parents, right, because it was about the authoring tool, right?
Okay.
So the authoring tool was that the parents and the teachers were already familiar with social stories so that they can see if the system was working.
Okay. So next question and comment. So I read it. Thanks for the presentation. It was all interesting. There are very important social, medical, and technological problems. Are the systems discussed by you are already in use? All of them,
yes.
I guess.
So I told you that the asthma symptom that the asthma one that I showed you, that one, was in use for many years, and there was a company that was licensing, and then the company stopped using it. And so, I'm always interested in collaborations. So especially with, clinical providers, because a lot of the times what we do, you have to have a professional, it can't be just me with an app. And so, we're very interested in it. The app that I showed you for PTSD, it's basically working. And so, we would be very interested if there's, a therapist out there in Poland that was interested in trying some of this technology. We would be happy to do it because, back to that ecological approach, we have to be able to understand how it works in different cultures, right? We're not all it's not all the same. And so they are working, and I'm always happy to look for new collaboration.
Well, that's great, because we have a lot of scientists here today, so
great.
I hope they all could hear you, and they will reach to you.
That's right.
I have 2 more comments. One question, one comment. So question is, where can we read in detail about the proposal for PTSD presented here? So I guess in Google Scholar, I probably
so you can see the main parts are in a paper that I have, and you can check the Google Scholar. And if you want to know details, again, I'm always interested in collaboration, so email me. I think my email is there somewhere. I wasn't able to chat, but email me. Maybe there's some funding, some grant that we can work on in Poland. I'd love it.
Yeah, it sounds really great. So now one more comment. Thank you very much, Professor, for an interesting and stimulating lecture. The discussed problems are very important and show enormous possibilities of cooperation in many areas. So,
and I think that's exactly right, because I think that that's the most important thing to me, right? Technology, can make a difference, and we see that it makes a lot of negative differences, but I think we can use it to have a lot of positive impact, especially in health and mental health. So I hope you take me up on my offer. I've never been to Poland, but I'd love to visit. I'd love to do research with maybe somebody out there.
Just one more question. I would like to ask if any other participants have questions. If so, please just turn on your mic now and ask them. Don't be shy.
Don't be shy. Or if you are shy, you can email me directly.
Yes,
you can be shy. It's okay. All right.
I have a question.
Oh, great.
Kasia here. I'm from Wrocław, a very beautiful city in Poland, and I'm a UX and business analyst in one of companies here in Wrocław. But it's really your story about helping people with autism make me think about people who have other different problems with for instance, with speech,
frontal lobe issues. Yes.
Yeah.
You're absolutely
So do you
right.
have something in this area? Because in my personal life, I'm struggling with this. My dad is after stroke, and I'm thinking about creating something like this that could support him. And he's using his phone, so that's why I'm thinking about this almost every single day.
Yes.
Do you know if something like this exists, or we can use already?
There are some apps online, but I think you're absolutely right. When we looked at, if you look at the cognitive impairment or disability that people with frontal lobe issues have, inability to plan, this need for very prescriptive information. It's true for many people, right? It's true for example, people that have some kind of traumatic brain injury like stroke. And so you might look for the official therapy is called, it's called a social story. So there are apps that have this, these detailed questions, right? The thing I like about this crowdsourced approach is that, again, there might be things that are specific. So, even there's general things like how to make a sandwich is going to be the same, here and in Poland, right? You're going to have to put the bread in the middle. And there's some things that might be specific. So for example, if you're in the snow, right? If you have to have your key somewhere. And so I think that that's where the crowd and having, local feedback is really important. So I guess I would try the app store and see if it's called Social Story.
Thank you.
Sure.
Great speech. Thank you.
Are there any other questions? Okay, Joanna Nowak, please.
Hi, hello. Your presentation was very interesting.
Thank you.
That I need to say. Yeah, I have one question, but I apologize if you just mentioned that and I just missed that. My question referring the PTSD app system, because you mentioned that it will use like app and like sensor, but more it will be more about like, I don't know, trying to figure out if somebody is in the position that it should be, like in the park or walking
Yes.
around. That's it. But my question is, are you going to use like other sensor and maybe other devices?
Yes. So I told you that we have, you know,
Something
we
happened
have,
with voice. Sorry, Joanna Novak. Can you turn on your mic? I'm sorry, Rosa, but something.
you hear
Okay.
me?
Yes.
Yeah, because there's other part of my question. Sorry for that. So yeah, like for instance, like stress level, like sensor that
Yes.
can figure out
Yes.
the stress level.
So can you see my screen?
No, we can see you.
Oh, too bad. All right. So I was showing you that we have the sensors on the phone because there's two parts, right? And so for stress indicator, we have a Fitbit, right?
Oh, yeah. Okay.
Right? Because once again, if you think about it, there's actually this fantastic company in Europe called eSense. And so that gives us galvanic skin response, but it's very awkward. It's like a ring and it has, you know, these, the wires that hang out. And so part of doing work is making sure that we're not stigmatizing people, right? If they have to be walking around with all these wires, then it's not very good. And so that's why we're going with a very simple, you know, Fitbit option to make sure that it's not stigmatizing for them to be walking around with all these wires hanging out. But, you know, for a while when they had the Google Glass, right, where we could look at the pupils for pupil dilation, there's some that are starting to get, you know, a little brain response from a sensor in the clip of the glass. But again, we're not there yet. And the most important thing to me is I'm pragmatic, right? I want it to work and I want it to be robust. And so sometimes we have to go with, you know, with less sophisticated technology so that we can get more reliable data.
Okay, because I assume that the data, this kind of data, will be used by AI, like artificial intelligence, to figure out if you can actually pressure the participant or not. For instance, that he or she is really like close to a breakdown, that you can't say something, oh, okay, you can stay like 10 minutes longer, because you can clearly see that the stress level is too high for that.
Yes, right. And so that's the other thing that, you know, that I've learned about PTSD, right? I've learned that, first of all, you know, this is called prolonged exposure because every day you expose somebody more. But the point is that you expose them for the same amount of time. So with this particular theory, you're not going to get them at 100% the first day, right? So that's why you have this hierarchy of stimuli, but you're trying to keep them there long. So I'm going to do the easiest thing, but I'm going to keep that half hour, right? Because this is back to, you know, theories of habituation and dishabituation, that we want to get people used to this low level of stress, and only day after day we're going to take them to different levels. So again, this is why I work with, you know, with people that have credentials, because we don't want to hurt people. And the other nice thing is that this prolonged exposure is really very well received, and again, it's a gold standard, very high recovery. But we don't know how it works, right? So that's the part with the machine learning that I kind of breeze through.
Well, okay, thank you for answering my question.
Joanna, thank you for asking.
That was very interesting.
Thank you.
Thank you.
So do we have any more questions?
Do you have any more speakers? I feel like I'm taking up all the time, Veronica.
Yes, we do actually.
I know, I'm just teasing. I'm saying because I've been on here forever.
Nobody is raising their hand, so maybe it's for
All
now
right.
we are done.
Don't be
So-
shy. Email me if you're a quiet person and don't feel comfortable asking. Email me.
So thank you very much, Rosa, for accepting my invitation. I'm very happy that you accepted
It was
it.
great. I'm always glad to, I'm of course an ambassador for Georgia Tech. I don't think we've had any graduate students from your university or from Poland. So I hope that somebody will come to Atlanta.
Yeah, that would be great, of course.
Thank you for your time.
Thank you very much.
Okay, bye-bye.
Bye. Okay, dear participants, we should have a break, but we have delay. So I guess maybe we will take a 5 minutes break, just very, very short one. And during that break, we will prepare Joe, our next speaker, to speak. So please go for a break for 5 minutes. Just open your window or drink some 2 sips of coffee, and please come back for then our next presentation.